Hello, my name is Giang Nguyen, student ID 32086582. Today, I would like to present the NBAC scenario. So firstly, I would like to summarize the case history. So this is the case for regarding Ruby, 30 years old, and her partner Sam. They come to antenatal clinic in public hospitals for her 34-week gestation visits. This is the first time they come to the hospital. Before that, all of her antenatal care was done at her GP and obstetricians. So Ruby is G4 3 P3 minus 1. She had 4 pregnancies, and this is the number 4. For the previous time, she has 2 children. The first and the second were 6 and 4 years ago, and they both have spontaneous vaginal birth at home, and with the weight 3.6 and 3.9 kilo at birth. Regarding the previous pregnancies, is also her number 3. It was about 18 months ago, and it was emergency cesarean sections cat 1 at 38 weeks because of a complete placental eruptions, and she had a stillbirth at this time. For these pregnancies, Ruby's was Ruby's was booked by obstetricians for elective repeat cesarean sections at her 38 weeks plus 6. And on the appointment today, Ruby concerns about 4 things. The first one, she's particularly anxious because the visits this time remind her about traumatic birth experience last time. Number 2, she's not happy because she felt the decisions on her birth plans was taken out of her hands. Next, she was worried about the recovery if she has cesarean sections again because with the previous cesarean section she hasn't her recovery was not as good as the spontaneous vaginal birth. And lastly, she's anxious because she's not sure about what the options for her birth this time. So move to step 2. I would like to identify the main issues for the case of Ruby. So with me, there are 3 main issues. The first one is the birth options for her pregnancy this time. We call it NBAC or next birth after cesarean section. The second is regarding her perinatal mental health, whether she has any problem with her mental health this time or not. And the last thing is woman-centered care practice. Whether have professionals already provide a good woman-centered care to Ruby or not. So to analyze in deeper the main issues, I would like to start with the first one, the next birth after cesarean sections. So in Ruby case, she has 2 options. The first one, she can go with cesarean section again. We call elective repeat cesarean sections as the recommendations of her GP and obstetrician. This means she will end up with another cesarean sections. The secondly, she can try vaginal birth this time. So we call it VBAC or vaginal birth after cesarean sections. So in these options, in this choice, there are 2 outcomes. The first one, if everything smoothly, she will have vaginal birth. But if she's failed to have vaginal birth, it will be end up with another emergency cesarean sections. So what's different between vaginal birth and cesarean section for this pregnancy? Firstly, we analyze about vaginal birth. So Ruby will have about 72 to 75% can successfully have a vaginal birth this time. And if she succeeds this time, she will have a shorter hospital stay, a faster recovery because this is a vaginal birth. She's also can avoid any complications related to multiple cesarean sections. For example, she can avoid major surgery, including multiple cesarean section in future. She can reduce the risk to having a placenta or rectia. She also reduced the risk of maternal mortality, and of course, because it is not cesarean sections, it will increase the likelihood of breastfeeding in postpartum. On the other hand, because vaginal birth, she have about 25 up to 28% will end up with another emergency cesarean section if vaginal birth fail. And because she's already have a cesarean section in the past, so when she go with vaginal birth, she will have a 0.5% risk having a uterine rupture in labor. And this risk is especially increased if they use inductions or augmentations in her labor. And apart from that, because this is vaginal birth, she will have any risk related to vaginal birth, such as perineum and pelvic floor trauma, anal sphincter injury, the risk of having instrumental birth. And how about cesarean sections? If she go with cesarean sections, so definitely she have a very low risk to getting a uterine rupture, and the risk is just less than 0.03%. Because it's a booking is a selective cesarean section, so Ruby can know what day that she can have cesarean sections. And this is not vaginal birth, so this means she will reduce the risk to have any problem related to perineum and pelvic floor issue, such as urinary incontinence and pelvic organ problems in future. But because this is elective repeat cesarean section, so that means it will increase the risk that she will have another cesarean section for future if she's pregnant again. It also increases the risk of any condition associated with the number of cesarean sections, such as hysterectomy, hemorrhage, blood transfusions, adhesion, placenta previa, placenta erecta, and any surgical injury. So what factor favoring and what factor reducing the rate of VBAC? To favoring likelihood of VBAC, the woman should have a previous vaginal birth. She should have uncomplicated and low risk pregnancies, and as the labor should be spontaneous, and she has a higher Bishop score. She also have the indication for her previous cesarean sections is fetal malpresentations. That means it will be low rate that repeat again. On the other hand, these conditions will reduce the likelihood of VBAC. They include the woman have no previous vaginal birth. The woman have complicated or high-risk pregnancies, such as the woman have obesity with BMI more than 30. The mom have advanced age more than 39. The pregnancies has any complicated or high risk, such as hypertensive disorder, complicated pregnancies, diabetes, or the current babies is predicted to have a high weight, because fetal macrosomias with the birth weight 4 or above 4 kilo, or the baby is a small baby, SGH, small gestational age. A last thing is the indication for the previous cesarean sections, dystocia, failure to progress, failure inductions, cephalopelvic disproportions, because these indications can reoccur again in this pregnancy. So we go back with Ruby case. In Ruby case, she's had a successful vaginal birth in her first two children. So that means she's have a previous successful vaginal birth. It's a likelihood to have a vaginal birth. Her age is 30. That means it's not advanced maternal age. However, she's had history of quite like history of a weight history of her child with a heavy weight, like not a normal weight. It's a quite big baby, like 3.6 and 3.9. So we're not sure whether this time her baby can reach 4 kilo or more. So we need to do a further assessment about that. We also don't have any information about her antenatal care, so we're not sure whether she has any like high risk, whether this pregnancy is high risk or not, whether she has any diabetes, hypertensive disorder or not. And the last thing is also important. That is the rate of a repeated placenta eruptions after having one times in the past will be 10 times higher than other pregnancy women who haven't had any previous history of placenta abruption. So that means Ruby will have high risk to have placenta eruptions again. Okay, so we move to the second thing. That means her perinatal mental health. I raised these concerns because Rubins have experienced Rubin had experienced directly of birth trauma in her previous pregnancies with emergency cesarean sections. And it's a placenta. It is a placenta eruption. So that means it's lead to extremely pain because the continuous construction of the uterus. And the outcomes is a bad outcome, is a worse outcome because it was a stillbirth, even though she suffered from emergency cesarean section. So that means she experienced pain, unexpected outcome of labor, stillbirth, medical interventions. And currently on this appointment, she shows the anxious, so that means symptoms of the mood and the conditions because the appointment in hospital remind her about birth trauma, even though it's already happened 18 months ago. And so that means it's a symptom of avoidance of reminder of the event. However, this is not enough requirement to confirm the diagnosis of PTSD, post-trauma stress disorders related to birth trauma. So we need to have a further assessment to confirm about that. On the other hand, it's also just simple anxieties or depressions. Okay, so I would like to move to management plans regarding the birth options, whether it's a VBAC or should we go with the cesarean sections again. So I need to contact to the GP and obstetrician to collect her pregnancy's informations, ask her to take in the more detailed medical history, family history, and obstetrician histories. As well, I also need to do the examinations on her to check the OBS, height, weight, BMI, urinalysis, do the fetal assessment with the abdominal palpation to take the presentations, the fetal row, fetal heart rate, and looking for the results of her investigations about glucose test or GTT, whether she has diabetes or not, whether she had a high blood pressure disorder or not, whether hemoglobin is low because related to anemia, and the result of the ultrasound to see whether the fetal development, whether it's a big baby or a small baby. And then I do the Edinburgh postnatal depression scale to see whether she has any risk to have a depression anxiety or not. If the score is more than 30, from 30 or above than that, I will refer her to the mental health midwife for further assessment. Apart from that, I try to explain to give all information regarding the VBAC and the cesarean sections, and I organize the counseling appointments with experienced obstetricians and experienced midwife about that. Explain to her that the decisions of her birth mode will be made based on her favorite. And the last thing is I organize the debrief appointment for her and her partner regarding her previous birth trauma experience. Thank you.